Yeah. Okay, let's get started. Yeah. So a lot of people ask me, what's the reason for this talk? And I thought, well, it's about sharing stuff that's happened to you, stuff that you know, and stuff that most people don't talk about. Which is about our health, especially men's health, and maybe even women's health as well. So before I start, shout out to Lagoon Hospitals and Marcel Ruth, my people, Dupe Odusi and Fola Laoye, the people that are taking care of me for the past month or so. So I went in ostensibly for malaria and a bacterial infection. And the great thing about medicine these days is that you don't have to stop doing that. You don't have to tell me what you want to do. You don't have to say anything. The machines just pick out everything you don't want to tell them, and so it wasn't necessary for me to tell them how I was feeling.
I think just look at the camera.
Wasn't necessary for me to tell them how I was feeling or how I was what was wrong with me. The machines just did all that, which I'm sure some of my brothers here understand, where even for a toothache, they go to London, they do themselves. You're laughing. Yeah, Drew, I have to measure you. Anyway, shout out to those people. So anyway, so I tried to also do some notes, because I think you guys are serious. I mean, my friends here is pretty serious, and the doctors are very serious people. So do some notes rather than just talk off ad lib and that just talking nonsense. So basically, welcome, wish you good morning again, and here's time to discuss some of these things that are important. I think that we should speak about. Unfortunately, or fortunately, the men have been rather I've rather been men, because men don't talk much about these things. But at the same time, even if I asked a friend, how do you make money? Or how do you keep your marriage together? Or how do you have sex with your wife? They wouldn't tell you that anyway. So not to talk of, their health issues. They certainly wouldn't talk to you about that. So I hope that at least in this forum, with Leye and Adeola, we can at least try and explore that and talk more about that. And I also used a quote from this lady, Elizabeth Browning. It's not death that men die from most. The same lady was the one that talked about the, let me count the ways. How many times do how much do I love thee? And I was telling people yesterday about a friend of ours, Jeff, who was talking about the Scarlet Pimpernel. And I said, I'm not sure that these Gen Zs or the millennials would even understand or know what we're talking about when we're talking about Scarlet Pimpernel. So same thing with Elizabeth Browning. But then again, that also shows our age, and and this same joys of aging. So also, we're talking about women. That's as you guys might know me, I have lots of my young aburos, and lots of them have said, Uncle Gbolly, I'm not coming to this. I'm too young. I'm 40. I'm 45, and I tell them that. But if that's the case, then most probably your boyfriend or your husband to be will be 50. So I think you should log in, and hey, that's I'm not sure some of them.
Are you muted? Can't hear you.
I can hear you, Ivana. So that's the thing with the young people. But with my older lady friends, they have their own stuff that we also go through with them as well. And so we thought, let's start with the icebreaker, which is I've got a IT person next to me. She's giving me hand signals, which I don't understand, but I think she will, she'll sort it out about the icebreaker, And then also with the men as well, before Leye comes in, Leye, I mean, if you've gone through his CV, as a doctor, working out of London and Eurocare, and Adeola is my really good friend. She's a surgeon. But she likes to, I mean, apparently in the scheme of things, the surgeons are higher than the doctors, or the surgeons don't like to be referred as doctors. But Adeola will explain that better. But Leye is cool. Leye doesn't mind to be referred to as a doctor. So they'll be here to talk to us about this urological, ED, menopause, pre-menopause, excuse me, all that stuff that we all don't really want to talk about. But I have so many stories. One that jumps at me was a really, 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 really good friend of mine who I asked to be part of the icebreaker. And I asked him, could you come and tell us, some things about your health, and he refused, or he recused himself by saying he's not ready for that stuff now. And I found that very a bit troubling, a bit depressing. But at the same time, I also have a story from another Egbon of mine who is over 70. He was laughing about a friend of theirs, or laughing at a friend of theirs, or about a friend of theirs who they went to the book club the other day, and he was taking forever to pee, and in the urinals, and they thought, hey, my friend, whenever you're ready, you are finished. When you finish, you finish. We're going back to have a drink. But nobody ever called in to ask him that, hey, what's wrong with you? Is there anything? Is there any problem? Is there any issue? But that's how men do. And then there's also the other one, which is pretty grim, about the friend of ours whose wife died in his bed. He had woken up, gone for his walk, gone for his gym, came back, done his own thing, and apparently, the autopsy, the lady was dead since 3 o'clock in the morning, and they were in the same bed. So these are the kind of stuff that I think we should try and unpack anyway. So let's do the icebreaker now. And Leye, can you choose?
Yes.
Yes.
Morning, Gbolly, and morning, everybody. Thank you. Firstly, thank you for inviting me to this webinar. There's so many faces, names that I recall here. Not because they're patients, they're people who are friends. So welcome everybody for giving up your Sunday. And thanks, Gbolly, for the introduction. So we'll just start with two aspects, or I'm going to give you 3 scenarios. 2 are right, 1 is incorrect. So I'll be interested to get a feel from everybody. Number 1, I stopped drinking fluids after 7 p.m. in the evening. Otherwise, I'm up all night passing urine.
Excellent.
Okay. Second one, although I get the normal morning erections, I'm not interested in having sex with anybody. Although I have normal morning erections, I'm not interested. I've lost my libido. Number 2. Number 3, how is it possible? I have absolutely no symptoms. How on earth can I have prostate cancer? Impossible. So those are the 3 scenarios. It'll be interesting to get people's views.
Fantastic. Yeah, okay.
Ask everybody to.
Okay.
Number 3, I would say.
Ask everybody to.
Yeah.
Which is not true, or which is true? What was the question?
True. Yeah.
Which one is a lie? Which one is anything?
I'll go with number 3.
So which one is a lie, gentlemen and ladies as well?
Everyone's saying number 1 is
okay. We can choose on screen. We can choose on screen.
Is there a chat?
Okay.
Oh, you can choose on screen. Okay.
Yeah.
Choice 1 is I stopped drinking fluid, otherwise I'll be going to toilet all night. Saying it to people again.
That's a good idea what you're saying.
So number 1 is I stopped drinking fluids at 7 p.m.
So if you want me to recap, I stopped drinking
I
first
think
at
the
7 p.m.
recap is better. Yeah.
I stopped drinking at 7 p.m. at night. Otherwise, I'm up all night.
Yeah.
Number 2, although I get normal morning erections, I've lost my libido.
Yeah.
Number 3, I have no symptoms. How can I have prostate cancer?
Yes, those 3. So which one is the truth and which one's the lie?
Which one is a lie? Yeah.
Yeah. Okay. Yeah, we've seen the results. Leye, it's very interesting. So you talk us through this.
Well, I'm sorry to be this, but I put all the whole true actually.
Wow.
I spread it that way because rather than give you a false thing, the whole true, and I just wanted to get people thinking because the variation, the reason why I put it as all true, the variation on symptoms are very interesting, and this is part of our discussion today. That people present in different ways, people present in all sorts of manner, and also essentially you can't discount anything. Is the point I'm trying to make. One person's symptoms is very different from another. And the fact that you stop drinking at night, you sit up all night, depends on what you do, your lifestyle, etc. Although you get normal erections at night, you've lost your libido. We're going to talk about all the multifactorial aspects of this. And also really the cancer thing. It's a common scenario where patients come and see me and they say, doctor, I don't know why I'm here. My wife has just said I should come for medical. How can I have prostate cancer? I'm absolutely fine. And I just look at the guy and I just say, well, guy, just sit down. Let's talk you through this. Fantastic. So sorry to throw you a googly like straight off, but I just want to focus attention on everybody. It can all people present with different symptom complex, and it can happen. Hence why the need for webinar like this, so we can all listen.
Wonderful. Thank you. Thank you very much, Leye. So Adeola, can you do your own? Adeola, please.
Morning. So, and thank you. I lend my thanks to Leye's, and it's also lovely to see familiar names in the audience. So mine are a little bit more general, because I never quite stick to the script. And so these are 3 facts about me. 1 is false and 2 are true, I think. Yeah. So the first one is I'm over 50, and so I no longer need cervical screening. Okay. The second one is that I have regular Botox injections to maintain my professional appearance.
Okay.
She does what?
Regular Botox injections.
Regular Botox injections to maintain my professional appearance. And the third one is, in order to maintain core strength, I start each day with 2 hours of hula hooping.
Wow.
With what?
Hula hooping.
Oh.
Wow. I don't believe the hula hooping. Sorry.
Okay, well, go ahead and vote.
Yes. Okay. So polls. Which one's the lie? Hula hooping. Oh, do that. Fine. Hula hooping, I don't believe. Yeah, hula hooping, I don't believe. No way.
I'm not sure you're supposed to influence other people.
Okay, sorry.
I think you're supposed to keep your thoughts to yourself.
She'll go, you know, it's going to do her own thing as well.
What was the third one again?
The hula hooping.
I can't remember the order in which I did them, so I'm going to read them out again. So the first one is, I'm over 50 and no longer need cervical screening. I have regular Botox injections to maintain my professional appearance, and I start each day with 2 hours of hula hooping to keep my core strength.
Okay.
Which one is a lie?
So which one's a lie?
The lie is over 50. Sorry. Yes, I've got 2 lies and a truth. So I've done it completely the wrong way. So my truth is the one that you said wasn't true, which is that I start each day with 2 hours of hula hooping to maintain my core strength. Wow. So over 50 and no longer need a smear is a lie. All women need cervical screening, and we're going to cover this a little bit in my chat. And the regular Botox injections, anybody who knows me would know straight off that's a lie. Nobody's coming near me with a needle for any reason, and particularly if it's not necessary. So, and again, I think that the fear of aging is a Western construct. I think that we should all embrace our increase in years. I think the alternative, if you don't grow older, you're dead. So I don't think getting older is anything to be ashamed of. And I don't think that we need to excessively use artifice to try and pretend that we're not getting older. So I'm not a Botox person. Strange you didn't pick that one out as not being true. Okay, so thank you.
Yes. So well, I would like Iona to one more person. Iona, I hope you're there. Could you?
I'm here.
Yes, please. Your two truths and a lie, because I know you're very, very interesting, crazy woman. Okay.
Okay. So I'm just going to just say three things. I think the first one for me is that sometimes I just wake up with pain. Feels like I've been in a fight. It could be my finger that hurts. It could be my wrist. It could be my ankles. Just somewhere hurts. I don't care what kind of exercise I do. Something hurts every day. Okay. The second thing is anxiety. Constantly worrying about life, worrying about money, worrying about health, feeling probably not seen, disrespected, or not being called to the table where there's conversation about money. And the third one is not being attracted to men my age. So a lot of people think that we're attracted to men our ages. No, we're not. Yeah. I'm only attracted to young people, 15 years or 10 years younger.
Okay.
So which one is a lie and which one is true?
I love it. I know what you're going to pick. Oh, gosh.
So, Ayana, would you repeat your three options?
Okay, so the first one was the pain that I just wake up and somewhere is paining me. I'm bandaged every day. The second one is anxiety, just worrying about everything, health, money. And the third one is that's just not attracted to guys my age anymore.
Okay. Okay.
It's easy.
So, it's easy, right?
Yeah.
Yeah. Okay, I'm going to round this up actually with my own two truths and a lie. Then we go back to. Yes. Okay, but finish yours first, actually. Sorry.
Okay, so should I say which one is a lie?
Which one's a lie? Yeah, which one's a lie?
They're all true. I went with Dr. Leye. There's no lie in any of it.
All true. Wow.
They're all true. First one, pains everywhere. Never thought I'm a very fit person, work out every day, still have pains. It could be my wrist this morning. Next day is my neck, something. Some people say spondylosis, we don't know. But apparently that's part of menopause. Second one is the anxiety, always feeling, worrying, who's going to take care of us? We only have one kid or two kids.
Thank you very much, Adeola.
Who's going to look after us?
Thank you
we have
so
enough
much.
Money for retirement. And the third one is that we're not really attracted to guys our ages anymore. So a lot of our guys think, oh, we're not attractive. The truth is that we're not attracted to you either at this point.
Oh, my Lord.
We like younger guys.
You're mad. I love it. You're crazy. I love it. Thank you so much. So anyway, I'm gonna wrap it up because we couldn't get any men to come over and be real with us apart from Dr. Leye. So my three were: one, I have to turn on the tap for 30 minutes to pee. Right? That's one. Maybe 20 minutes. Like when you're a child or when you're babies. Then second one was, even though you exercise, running down the stairs or running up the stairs, you're out of breath. And you wonder what I exercise. And the third one was, you need to take pills to get hard for your wife or your girlfriend. So which was the lie, which was the truth? What I need to do.
We don't have the poll on the screen, Ayana.
Yes, there's a poll on the screen now, yes.
Please repeat the options.
Should I review the options?
What was the second one again?
Okay, let me just start from the first one. First one is turning on the tap so you can pee, because it's hard to get started. Right? Second one is being breathless even though you exercise. can't run up the stairs, can't run to follow more. The third thing was leaving pills to be hard and not telling your other half, your girlfriend, your wife.
They're all true.
That's what Adeola's answer is. That's your answer. I love you. You know, I love you.
I know you.
You know, I love you. Don't say you know me, I just say I love you. No, there's one that's not true now. Abba. No, really. 20 minutes on the tap. Oh, come on. Okay, so I think that's a lie. As we can see, 50% said was a lie. Leye, I think it's time for you to take over.
Excellent. Thank you so much.
Thank you very much.
Thank you. Well, what an interesting conversation. What an interesting conversation thus far.
Okay.
Just getting starting the conversation. I'm going to try and share my screen with you all, and give me 1 second. Right. Can you see this?
Yes.
Excellent. All right. Well, thank you very much, Gbolly, for the introduction. The joys of aging. Thank you for this opportunity in this webinar. It's going to be an interesting conversation. Now, there's a number of areas which we'll touch base on. And being a doctor, forgive me, we don't get the joy of talking to non-medical people too often. So I've tried to reduce the medical terminology to the best of my ability. So apologies if it gets a little technical. So we start with more of the common symptoms that we see, urinary symptoms in men. We'll talk about prostate disease, in particular benign and malignant prostate disease. And then we'll finish it off with a good old topic of sexual or erectile dysfunction. So really, when we start the conversation with a lot of men, when you're talking about urology, you're often talking about the urinary tract, and that's the bladder and the prostate. The first question I often ask people is, what is the function of the bladder? And a lot of patients friends look at me and say, what am I talking about? Essentially, the function of the bladder is to store urine. And most importantly, for you to be able to void when it's socially acceptable. That socially acceptable thing is a bit of an interesting one, because in a lot of our patients, the socially acceptable varies depending on what part of the world you live in. A man who's playing golf all the time wouldn't really care because he's able to do his business behind a tree in a golf course, whereas some individuals, if you're a bus driver or a pilot or something, you can't really go to the toilet as often as you like. So the whole social acceptable thing is something to be wary of. Also with age, if you look at the two extremes of age, as a child, as an elderly person, that socially acceptable becomes a bit of a problem, because with age, you start developing urinary incontinence and all the features that relates to that. So let me start the conversation really talking about getting up at night. That's the first thing that becomes bothersome in a lot of patients. And that's defined really by getting up more than once at night. It increases with age. We know that 50% of men over the age of 60 have this issue. And the impact of it is quite significant. Okay, with sleep deprivation causing exhaustion, mood changes, increasing incidence of accidents, and also cognitive impairment, just not remembering things, not functioning optimally at work. We also know that 25% of falls of older individuals happens during the night, and most 25% of this is due to the fact they have to get up at night. So getting up at night is a problem. What causes it? Primarily thirst disorders, and there are two thirst disorders that we see. Diabetes mellitus, which you all know about, a lot of you are aware of this. This is due to poor sugar regulation. And another proportion of diabetes insipidus. This is the reduction in a hormone produced in a part of the brain called the hypothalamus, and it's stored in the area called posterior pituitary. And this is the hormone's antidiuretic hormone, i.e. stops you peeing at night. When you go to bed at night, your body normally produces this hormone, which reduces the kidney production of urine. And if as you get older, your brain and your kidney becomes insensitive to this hormone. So you produce more urine at night and you get up more at night. It's a normal age phenomenon. We see it in men who have hypertension, who are on diuretics, people have cardiac failure, nephrotic syndrome, a number of other disorders. But lifestyle pattern, these are the most important and very ones you can really regulate. Excessive water intake. I'm not talking about alcohol. Some people think they get a bit parched at night, so they're down a liter of water at night before they go to bed. This will cause you to get up at night. It's really that simple. And obviously, we mustn't forget the old, once you've had a few pints of beer, or you've had your XO, or you've been out for dinner, a few glasses of wine, you follow it down with a double espresso. I look at people that do this and I'm like, you're going to be up all night. So alcohol and caffeine, definitely diuretic. So be aware of that. Well, how do you manage this in a lot of patients? We see patients, we ask them to reduce their caffeine intake, reduce the alcohol intake, very common. Sorry, my screen just froze for a second. Give me a second. Right. So improving diabetic control is also by modification in lifestyle, sort out your diabetes, drugs that we use for patients who have diabetic-related issues, and medication we use for prostate and the various surgical platforms that we use. Now, a lot of my patients will come to my surgeon and say, Doc, what is this prostate thing? As a lot of the Nigerians pronounce it wrong to do it. I think it's prostrate, as a lot of them say. So what is this prostate issue? Basically, it's an organ that sits at the base of the bladder. It's one of several accessory sex glands that we have as men. There's several of which they're there. They're located at the base of the bladder. It's responsible for the production of nutrients such as zinc and citrate, which help the survival of male sperm. It also facilitates the process of ejaculation. And you wonder how an organ can facilitate that. Essentially, within a man's prostate, there's smooth muscles. So when a man ejaculates, it's a sympathetic response. It causes contraction of that prostate, and that allows antegrade emission of sperm. With a lot of our patients, we've operated on them and removed their prostate. This thing, I don't think we can see my cursor, it's called the seminal vesicles. That's where sperm is stored. So when a man ejaculates, this whole mechanism contracts and allows the emission of sperm. So when we've done a prostate surgery, we remove all this. A lot of men suffer from retrograde ejaculation, or once you remove the prostate for cancer, again, they have difficulty in producing sperm because we remove the whole process. Now, in terms of symptoms, we kind of define into two areas. When you lose the ability to store urine or when you have an obstructive symptoms. And these are some of the things you'll see. In a lot of patients, you can have an enlarged prostate, what's called hypertrophy or an enlargement, but this is not really a problem. I've seen men have big prostates, just like women have big fibroids. In Nigeria, a lot of men have also big prostates, but it doesn't necessarily mean they have symptoms. The cohort we worry about is those that have obstructive symptoms, and that's what makes their life miserable, where they have frequency, urgency, etc. Some of you might be familiar with this naughty boy of Brussels, and I've seen patients come to me and look at this young lad in admiration, thinking, once upon a time I could pee like this. Doc, what do I have to do to be able to gain this back? Because this is clearly a problem. So what do? There's a host of medication. Again, without going into too much detail, there's a group of medication that we use. Some of them you'll be familiar with. You'll be familiar with some of these medications in an effort to improve symptoms. And there's a host of surgical procedures, again, without going into too much detail, which we use to improve the patients. And their all benefit is to relieve the obstruction, improve their symptoms. Right, let's address the elephant in the room, really, as far as men's health is concerned, prostate cancer. This is an article that was published in, I think, Nature a number of years ago, looking at men and really high-profile men. And when you look at African-American, high-profile men who quite commonly come out publicly and tell you they have prostate cancer. Now, I could be wrong, but I'm not aware of any prominent Nigerian who quite openly come out and tell the whole world, I have prostate cancer. I think this is the kind of narrative we need to try to improve, because the fact that you have prostate cancer is not a sign of weakness. It's not a sign of necessarily mortality. People who survive prostate cancer and live to very, very, very old age. So trying to break that dogma, that opinion that prostate cancer equates death, I think in this webinar, I'm hoping we can dispel that myth and people can talk openly and freely about prostate cancer. So I'm going to just touch a little bit about issues around prostate cancer. We know the incidence is increasing. According to the Western world, there's a reduction in mortality. And the reason why there's a reduction is the early stage of presentation and more aggressive treatment. Sadly, this is not the case in Nigeria, because a lot of people do not present early enough, in my opinion. Hence, we're picking up cancer quite late, and often it's aggressive by the time we pick them up. Screening is a real issue, and it's a real political issue all around the world. And there are certain criteria we look at when we're dealing with screening. So you want to know the disease burden, you want to know the natural history, the accuracy of the diagnostic test. Again, we'll talk about that in a little while. The acceptability of the diagnostic test, the efficacy of treatment, the availability of resources and health services, and really the economic implication. This is the WHO criteria for screening. Women live at least a number of years more than men, and there's a reason behind this. Women have two areas of screening. They have pap smear for cervical scare, and they have mammograms for breast screening. Men have absolutely nothing. We do not have a screening, screen, and there's been a huge debate worldwide about why we should and should not screen for prostate cancer, and opinions differ. And this is the WHO criteria for screening. Regrettably, prostate cancer does not fulfill this criteria, hence why the difficulty in making that known. When we're talking about the burden of prostate cancer, we know what it's like in the West, we know roughly the incidence. It's very rare in Asia. Could be their diet, we don't know. Very low in Thailand. We don't really know what the etiology, what the prevalence or incidence is in Nigeria. We do know the lifetime risk in a lot of men. One thing for sure, we do know that with age, prostate cancer incidence grows up. It's interesting, this graph looks at men in their 50s. I have diagnosed men in their 30s, Nigerian men in their early and late 30s with prostate cancer, which is unbelievable. Wow. And when a 30-year-old walks into my surgery, I'm like, yes, he's got a raised PSA. You think they've got an inflamed condition called prostatitis, but I've gone ahead and investigated and diagnosed prostate cancer in men in their 30s. So in Nigeria, we don't really feel the normal processes, and we have got to be sensitive to this. Again, the natural history of prostate cancer, in my opinion, is poorly understood. There's a lot of competing comorbidities, either die of heart, hypertension, diabetes related, or strokes before they die of their prostate cancer. We know that those that have high-grade and high-stage disease are more likely to die from them. We're not really sure which cancers cause a problem. We know that a lot of patients die of it, rather than with it. They die of it rather than with it. We also know that really, on autopsy data in America, 80% of 80-year-olds have prostate cancer. It doesn't mean they're going to die from it. It just means they have it and they die with it, not necessarily from it. So the whole issue of prostate cancer, we've got to really pull our head out of whatever it is and give it a bigger thought. And this kind of webinar helps us in that conversation. We know it increases with age. And if you look at the little graph on the left side, those of you that have had siblings with prostate cancer, if your father has had prostate cancer, then your incidence raises to 12. If you've had a sibling that's had prostate cancer, then your incidence rises. If you've had two siblings that have had prostate cancer, again, increases your incidence. So you've got to go for your annual checkups. This is the real dilemma with prostate cancer. We don't know the difference really between the indolent prostate cancer and the aggressive prostate cancer. We call it the pussycat and the tiger. When we diagnose some patients, there's some markers we use. We don't know whether by diagnosing it, they might live for another 40 years with their cancer, or those who might succumb to their cancer very early. So the science is still not great. Wow. Now, in terms of diagnosing prostate cancer, we have some tests that we do. Some of you will be aware of the PSA. We talk about that today. Yes. And I'm sorry to say, it's the dreaded finger. A lot of patients despise the idea of having an examination to examine their prostate. Now, you know, imagine going to, some of you might be Arsenal fans, you go to the Emirates and they say they'll give you a free ticket to go through the turnstile if you would allow them to examine your prostate. I think a lot of men will say, you know what, you can stick your ticket, I'm not coming. So the whole examination of the prostate, men do not like the whole appraisal of examining the prostate. And obviously, if you feel the prostate, you know, another thing to comment about, in Nigeria, or in the Western world, the finger examination is done less and less because they're more diagnostic accuracy. The finger is really, although your finger as a surgeon is educated, we like to think we can feel abnormal cancers. We don't tend to feel that much in the Western world anymore because they've filtered out advanced prostate cancer. You don't see that very often. Whereas in Nigeria, we see a lot of men with aggressive prostate cancer. When I examine them, you can examine them just by your finger within a matter of seconds. This is hard, this is irregular prostate, this is prostate cancer. We don't see that in the West very much. So the finger examination is not done very often. And when we diagnose, we have to do a biopsy, we talk about that. So the examination is a real issue. And a lot of men run a mile. The idea they come into my surgery, the first thing they do is looking at my hand. How big is this doctor's hand? How on earth is he going to stick his finger up my bottom? You know, who do you think he is? You know, there's a taboo with that. So a lot of men don't come forward because they're like, doctor, you must be kidding me. You're not going anywhere near me with your life. But the way things, yes.
Well, sorry. So I just wanted to break it up to add some humor to it. I actually didn't mind when the doctor wrapped his finger down my
I like that, wrapped his finger.
Yeah, I didn't care. I didn't mind actually.
Well, you didn't, but a lot of men walk into my surgery like, you
course.
know, also there's the cultural aspect, you know, we're talking about Nigeria. You know, I deal with a lot of patients in the Middle East and they come with their experience that they're like, doctor, never, it's never going to happen. You're not going to examine me. Because culturally, it's just seen as, it's, you know, it's just one of those things. So even Nigerians, some of our patients say, doc, I'm so sorry, find another way. You're not doing this. So, you know, so thankfully we don't do this anymore. I mean, I put this slide up, it's just in jest because we laugh at it now. But during COVID, it wasn't funny when there was lack of PPE and we were rationing our PPE and who we examined, who we didn't examine. So the way we do this now, we have MRI and MRI gives us a bit more accuracy. You know, imagine an orange and the seed of the orange is a cancer. You can't really examine the seed by just wrapping your hand around the orange. You have to do a scan to look at it. So we now do MRI more and more frequently. The only problem is it's quite expensive and it's not readily available to the public in Nigeria. Those that can afford it do have an MRI, but I think this is the way forward really. And in the MRI, it picks up area of what's called restricted diffusion. And when we do that, we often do what's called an MRI ultrasound fusion biopsy to diagnose the cancer. So that's quite useful to do. And the way we do is we target those lesions and we biopsy. I'll talk a little about PSA. Let's keep this simple. PSA is a blood test that a lot of patients have to diagnose prostate cancer. It's secreted by the epithelial cells in the prostate. Funny enough, it was first identified in a forensic rape case where they've identified this antigen in the semen. That's how PSA was first identified. And the function of it is to help coagulation of sperm. Now, or to prevent coagulation, you might wonder what is relevant in this. When a man ejaculates and is trying to procreate, have a child, the female enzymes, the female body is very, very hostile to the sperm. That's why we produce ejaculates of millions and millions of sperm, because only one survives, only one gets to the destination, because the female body kills them all. And PSA is a hormone, an enzyme, which helps the survival of the sperm within the vagina and in the uterus. So the normal level is under 4, and we use it to detect and stage prostate disease. This is quite important. PSA for the prostate is prostate specific, not cancer specific, i.e. there are a number of other conditions which can cause a raised PSA, and please be aware of that. A normal PSA I've mentioned to you is 4. If it's raised, then we need further investigations. Now, moving on, for a lot of our men who choose to have treatment for prostate cancer, and the question we ask them is do they feel lucky? I ask that question. Wow. The reason I do this is because we know that surgery for prostate cancer has potential side effects, in particular two, which can be non-palatable to the vast majority of our audience here. Continence. The idea that if you remove the prostate, it affects their continence, so they might be wetting themselves initially after surgery, and most importantly, erectile dysfunction. Although there are technology now, especially with the use of the robot, which reduces the incidence of incontinence and reduces the continence, the erectile dysfunction. This is a robot in one of my hospitals in UK. My disclaimer, I'm not a robotic surgeon, but this is one we have in my department. And using the robot, you're able to do quite complex surgery. And you can just give you some concepts. In the good old day, we'll do a big cut, whereas in the robot, you've got 5 tiny incisions. We'll have to get a big hand into your pelvis. So imagine the amount of dissection one has to do. Now with the robot, and Dr. Olaitan will probably give us more. She's a robotic surgeon, and she'll probably give us a better insight in this if she can. But with the robot, you're able to dissect and get into the anatomical pelvis. And a Nigerian pelvis, believe it or not, as big as we have what's called an android pelvis. Robotic surgeons hate the Nigerian pelvis because we have narrow pelvis. Although with our big body, the pelvis is called android pelvis. It's very narrow, and we have big prostates. So trying to get into the pelvis to operate is a real challenge. But with the robot, you're able to get into the finer points of this and do really fine surgery. This is where the nerve supply, you're able to preserve the nerve, you're able to preserve the continence of the patient. This is a 4-point robotic thing. Again, without going into too much detail, using the robot, you're able to do really fine dissections and do robotic surgery. So patients are doing much better. Now, moving to less surgical areas, you're probably asking, why do we have prostate cancer? How can you prevent prostate cancer in men? So there's been various thoughts, the use of green tea, soya beans, selenium, vitamin E, lycopenes, which are high in tomato. If you look at the Mediterranean diet, for example, high in tomatoes, full of lycopenes, antioxidants, phytoestrogens, all things are very good. I didn't really want to know the Nigerian diet enough to say, okay, if you eat eforiro or egusi, it prevents this. I don't really know because I don't think the science is there. But there are various things in the Western diet that we know that can cause it. How do you prevent it? There's been a number of studies looking at this and not very effective. And when we look at the future of prostate cancer, chemoprevention, they try various drugs, better detection, better awareness, gene therapy. These are all things that have been done. And whether or not the incidence of prostate cancer is very high in Nigeria. So we're not sure it's nature or nurture, diet, animal fat. I have to really label this point. If you like your suya, or you like your was it Leye a few weeks ago? All the ram that all you men were eating and women, this is high in animal fat. This increases antioxidants, this increases your risk of prostate disease. So by damping down animal fat, chicken, fish, poultry, not a problem. But meat, suya, all these things are horrible for increasing your risk of prostate disease. Hormones, we've looked at this, it's quite an interesting thing. We wonder why men have prostate cancer early in Nigeria. Like I said, I've seen 30-year-old men with prostate cancer. Our mothers, believe it or not, our mothers in the first trimester have a higher testosterone in the first trimester than white women. So it is thought that the men have a higher exposure to testosterone right from in utero, whilst you're inside your mother. So by having a higher testosterone in utero, you might even accelerate the incidence of prostate disease in young men. So this is quite novel, and some of you might not be aware of this fact. Right, I'm going to move on and talk about erectile dysfunction. I'm mindful of time, I'm going to take up time. Erectile dysfunction is defined as inability to attain or maintain penile erection sufficient for satisfactory sexual performance. Now, we all think intercourse, or we're taught intercourse is all about procreation. But let me demyth something for you. Is sexual activity beneficial? These are some very good trials that have come out. This is the American Duke longitudinal aging studies. Yeah. The frequency of intercourse is a significant predictor of longevity of life. A Swedish study came out. Early cessation of sex is associated with premature death. And most importantly, this is a Welsh study in the area, I can never pronounce it carefully, in Wales. 50% reduction in cardiac death with more than 2 orgasms a week. So ladies and gentlemen, like you need an excuse to have intercourse. If you want to live long, you need to remain sexually active. Okay? Some of my patients, by the time they're 70, like, doc, I'm fine, I don't need this, blah, blah, blah. This has some strong evidence. I don't know how they conducted these trials back then. In modern time, I think we won't get away with conducting these trials. But be aware, sexual activity is of great benefit if you want to live long. So the problem we have is really the vast majority of our patients do not come forward. This is the Massachusetts Aging Study. Only 10% of our men come forward. And when you look at it, if you look at the numbers in America, I quite like this Florida flag. Some of you might get the joke here, some of you might not. In America, quite a portion, but in Nigeria, we don't really know, how many patients have erectile dysfunction, who comes forward with it, but we do know roughly only 10% seek medical advice. This is an advert in a Western world billiard, on a billboard. We wouldn't get away with this in Nigeria. So the attitude to sex is very different. In some Scandinavian country, they wouldn't blink an eye with an advert on a billboard like this. In Nigeria, I think whoever put this up will be struck down. And so attitudes differ. So I want to float the concept of Adam and introduce you to Adam. Adam is a syndrome called androgen deficiency in the Asian male. Okay, Adam is an acronym. So the other term is essentially it's like the male menopause. Okay, and what does the man suffer from when they have Adam? Okay, if you look at the list of symptoms here, a lot of men, a lot of you on this call will probably think, you know what, I better go and get my testosterone checked. There's lack of concentration and lethargy, nervousness, impaired memory, depressed mood, insomnia, decreased libido, erectile dysfunction, periodic sweats, reduction in strength, and redistribution of body adipose, i.e. you put on weight, you put on fat. So this is Adam. This is an Adam syndrome. And essentially the way we do it is to assess the man's testosterone. And by improving their testosterone, you improve their quality of life, their muscle mass, their memory, their bone density. It's like the female menopause without going into too much detail. And a lot of men that have this syndrome, we give them testosterone replacement therapy, and that comes in different formats: implants, injections, or transdermal medication. So when we're talking about erectile dysfunction, a lot of the causes we see as doctors are organic. And obviously there are a lot of psychogenic factors. Organic factors, if you think about it, as someone who's diabetic, this problem becomes a gradual onset. It's a constant problem. It affects non-coital erections, i.e. early morning erections, occurs in under circumstances. And there's a psychogenic aspect. So imagine now psychogenic, let's talk about COVID. During COVID, where people are worried about work, employers, etc. So that's more of psychogenic ED. So it's a sudden onset due to the pandemic, for example. It varies in degree under different circumstances. It's associated with the presence of normal. So you still wake up in the morning with normal erections. Ladies and gentlemen, it is normal and physiological for a man to have an erection 6 to 8 times at night whilst they're sleeping. Believe you me, it's not sexual arousal, it's normal physiology. Okay, so when you wake up in the middle of the night to pee as men and you find you have an erection, it is not necessarily a sexual thing. It's just your normal body algorithm, a normal rhythm in your body. We'll talk about this at the end, but with the vast majority of our patients, there's organic and psychogenic factors with ED. We know that it's a vascular problem. So a lot of men, it's due to the reduction in inflow of blood to the penis. So if you have atherosclerosis, hypertension, diabetes, or sickle cell, or you have venous problems, or they have an actual problem with the penis. So if you have diabetes or you have sickle cell, you've had priapism, that damages that area. This is what we do as urologists, without going into too much detail. The first question I always ask a lot of men if they lost their early morning erection. In America, they call it the morning wood. If you lost the morning wood, then you're thinking more the organic. Like, they're diabetic, they're on medication. There's a number of things that we look at. These are a host of medications that can cause erectile dysfunction. We always check the hormones in the morning. Believe it or not, I'm sorry to break this to you, gentlemen. Yeah. Your testosterone is highest in the morning. Yeah. and it's lowest at night when you're with your loved ones.
Mm.
So unless you want to reverse the situation where you have time in the morning where your testosterone is high, you're in the office. So it's at night when your testosterone, when you're with your loved ones, your testosterone is at its lowest. So when we check your testosterone, we always check it in the morning, and we always check their cholesterol and check their fasting lipid. So this is quite interesting to bring this to you. Like if you look at the risk factors for coronary artery disease, these are all very common in Nigeria. They smoke, they have high blood pressure, they have high cholesterol, and they're diabetic. Exactly the same risk factor for erectile dysfunction. So we have a thing called endothelial dysfunction, which is the common denominator. Now, this is a useful slide. If you look at the blood supply of the heart and the blood supply of the penis is so small compared to that of the heart. So if you already have coronary artery disease, most probabilities you already have erectile dysfunction. This is a common scenario. We see it. Some of my patients that come into my consulting room. Doctor, look, I'm having difficulty flying the flag. And I look at them, I'm like, well, you can see this individual from a mile away, that there are factors. They have a thing called a metabolic syndrome, where they have low testosterone, they have high body mass index, they're hypertensive, they have high cholesterol. It's not a surprise they can't get it up. So by losing weight, exercising, doing all these things, getting slimmer, all this becomes a factor. And the fact they can't even see their penis is a real problem. So we always encourage our patients, really, we go through cardiovascular risk factors. I'm always very impressed with the amount of level of exercise that a lot of people are undertaking now, and it really would benefit them. This is just an interesting slide. I remember when Viagra came out, this was quite an interesting slide. Scenario we see a lot of, where a lot of our old boys used to come for a doctor, give me my blue pill. I want to buy Chelulon. And the wives that are looking at me say, doctor, if you prescribe this man anything, there'll be trouble. But it's good for their physiology. It's good for man's physiology to have this. It's a wellness. There's a concept that this is to do with promiscuity and everything, but it's not. It's just for their man's wellness. Now, again, I won't go into too much detail about the treatments, but just a few things to bring to your attention. You might not be aware of this, but the whole process of erection begins with an amino acid called L-arginine in the man's penis, and there's a gas called nitric oxide. We actually have a gas in the penis where there's an enzyme called nitric oxide synthase, which breaks this amino acid into nitric oxide and allows this to diffuse. And this is the pathway, again, without going into much detail. When we prescribe medication, Viagra comes in a packet of 4, and you're probably wondering why on earth they put it out in a packet of 4. And there's a reason, there's a science behind it. We know that if you give a man a packet of 4 Viagra, whatever dose, only about 54% efficacy. Whereas if you give them 2 packets, if you give them 8 attempts, they get more comfortable with it, and 80% success rate. So we often prescribe 8 tablets for all our patients as a first line, just for them to get comfortable with it. Wow. You also wonder of all the drugs we use, why we use certain drugs, and we tailor as doctors, we give certain drugs to certain people based on their needs. For example, Viagra here has a short half-life, i.e. it's in the body for a short time. So a lot of our older patients who worry about the risk of blood pressure problems, having a stroke or having a heart problem, they like Viagra because it's fast-acting and it's in and out of the bloodstream. For our younger patients who have erectile dysfunction, who are diabetic, for example, we use Cialis. The American, they call it the weekend pill. That's 17.5 years, a half-life of the drug. I.e., if you take it on a Friday, you're good Saturday and Sunday, just 1 tablet. So depending on the patient's needs, we use different drugs to suit their needs. Again, patients come to me and say, look, doc, this tablet, I don't like it. It hasn't worked. It's not working. I always ask them, tell me how you took the drug. They say, well, I went to my wife for dinner. I had sticky toffee pudding. I had coffee. I had this. I'm like, look, the problem is some of these drugs are not absorbed by food. If you have a fatty food, your body doesn't absorb the drug. So we always say, look, if you're hoping to get lucky that day, have some salad. Your wife will see you coming a mile away. Keep your diet light. So at least allows a rapid absorption of the drug rather than going out and having lots of alcohol, having lots of dessert, and then wonder why Viagra hasn't worked. So obviously there's a lot of anxieties about the drug. Again, we've stopped using them. And we sometimes offer some of our patients a small dose of 5 milligrams of tablets, which works very effectively. And a lot of our patients, so without the need for reaching for the drug cabinet, we find this quite helpful.
Thank you very
For the
much. Leye, sorry, I have to interrupt you. It's 12 o'clock.
I've almost finished.
Yes, you almost finished. Okay, fine. Because it's been actually fascinating. I have so many. Yeah, I've taken my notes anyway. So
it's almost done. It's almost done. Give me another 2 minutes. So in terms of non-oral drugs, when you go to see a urologist, there are things we use, injections we use. You know, if people have spinal injuries, these are some of the drugs we use to improve the quality of the erection. This is an ultrasound machine. This is a vacuum pump for those who've had surgery. In some very rare circumstances, we insert implants. Diabetic patients, post-sickle cell patients. This is the electron microscope of someone with sickle cell. You can see it's very thin muscle. That is useless penile muscle. So we replace it. Different types of implants that we use. This is a slide from my colleague. Again, I won't stop you all having your dinner, your lunch today.
Take pictures.
Please don't take pictures. Without being too gross, this is what by putting penile implants in, this is what it ends up doing. And I'm going to stop there. Thank you very much.
Wow, Leye, this has been fantastic.
Now, Gbolly, I just want to share one slide with you because a lot of the women on the call are probably thinking, you know what, this is all good for men. What about for women?
Exactly.
What about for men? What can you do for the women? The loss of libido. And I'll just put this slide and I will not say anything.
Okay.
We'll work it out.
Okay.
Slightly more complex. Enough said. Women slightly more complex than men.
Yes.
So we're very simple, easy to the point. Women, not so easy. Right. I'm going to stop there. Thank you so much.
It's the right way for Adeola to get into this thing. Adeola, so hey, the ball is in your court. Fantastic.
Fascinating talk, Leye. I learned lots. I'm just going to share my screen and go straight into my discussion. Bear with me. So I'm talking, come on. Apologies. I'm talking specifically about cervical cancer because there were so many topics that we could have covered this morning, but I thought that I would keep it to one subject. And the reason why I think that it's important to understand about cervical cancer prevention is we still have a huge problem in Nigeria. It still remains a very common disease in Nigeria, and it is potentially preventable. It's interesting because Leye alluded to the fact that a lot of people, certainly in the Western world, are not afraid to share the fact that they've had prostate cancer. The situation is not the same with cervical cancer. A lot of people are very reticent to talk about it because it has certain negative connotations. And I think that's rather sad because it does reduce the opportunity for people to understand that this is a potentially preventable disease. And to illustrate, in the United Kingdom in 1988, call-recall screening for cervical cancer was introduced, which means that all women who are registered with a GP get a regular invitation to have screening for cervical cancer. Before that, screening was opportunistic, which meant that women at low risk were screened very frequently and women who were at high risk were not screened at all. And it had no impact on the rates of cervical cancer. But from 1988, the rates of cervical cancer have fallen as coverage for screening has gone up, with a consequent reduction in death rate from this disease. And screening saves up to 5,000 lives a year. Now, we understand, our understanding of cervical cancer is enhanced because we know what causes it, unlike a lot of cancers. We know that cervical cancer is caused by the human papillomavirus, which is also referred to as HPV. Now, HPV is a family of viruses. There are about 100 of them. They're the viruses that cause the warts on your fingers and the verrucae on your feet. Two types affect the genital tract. Low-risk HPV, the HPV types are denoted with numbers. So type 6 and type 11 low risk HPV, they cause genital warts. High risk HPV, of which type 16 and 18 are the most common, but there are about 20 other types, are associated with cervical cancer. And what's important to understand is that high risk HPV does not cause any visible lesions. So the fact that you have high risk HPV doesn't mean that you're going to get genital warts. And likewise, the fact that you have genital warts doesn't mean that you're at increased risk of cervical cancer. So it's important to draw a distinction between the two. HPV infection is really common. Most people are exposed to HPV the first time they have intimate relations. And I don't say intimate relations because I'm being coy. It's that HPV is transmitted by skin-to-skin contact. It doesn't need penetrative intercourse, and consequently, condoms don't protect. As a consequence, about 80% of women will have high-risk HPV at some time in their lives. Most of them will clear it within a couple of years. Most won't even know that they've had it because it causes no symptoms. But what we do know is that if HPV persists, the risk of cervical cancer increases. High-risk HPV causes about 99.7% of all cervical cancers, but only a small percentage of women who have high-risk HPV will go on to have cancer. And I'll try and illustrate. This is a very simple schematic diagram about how HPV causes cervical cancer. So HPV infection occurs, that's 4 out of 5 of us. Most people will clear it within 18 months and their cervix will remain normal. In some women, HPV infection persists, and it is the persistence that leads to the precursor lesions of cervical cancer. But we can still do something about it at this point. If the woman goes for screening and the lesions are detected and treated effectively, her cervix goes back to normal. Women who don't go for screening are at risk of developing cervical cancer over 10 to 30 years if they have persistent HPV. Again, important, HPV causes no symptoms. So if you didn't go for screening, you wouldn't know about it. And that's my emphasis is you really must go for regular screening. So because we know about HPV and the way that it causes cancer, it allows us to devise strategies for preventing cervical cancer. So broadly speaking, there are 3 levels of prevention. One is protection, lifestyle changes that can put you at less risk of cancer. The second is primary prevention, which is a vaccination against HPV. And the third is going for screening, which I've already alluded to. So in order to understand what lifestyle changes you might make, we need to appreciate what leads to HPV exposure and persistence. So HPV exposure, sexual activity, well, you can't put a ban on that, but you can try and modify your lifestyle to reduce persistence. So one of the main causes of HPV persistence is smoking. A lot of people know smoking causes lung cancer. A lot of people don't know that smoking increases the risk of cervical cancer. Fortunately, I think in Nigeria, not a lot of women smoke, but if you are a smoker, stop. There is no safe level of smoking. And a lot of my patients have switched to vaping. And again, vaping is new and we haven't studied it, so we just don't know. So I can't say that it doesn't have any risk. To reduce your risk, it's important to completely stop. The other cause is HIV infection. So HIV reduces the body's immunity and so you rely on an intact immune system to clear HPV. So if a woman has HIV infection, she's less likely to clear HPV and she's more likely to be at risk of cervical cancer. And the third category is recipients of organ transplants. If you have an organ transplant, a kidney transplant, a liver transplant, you're put on immunosuppressive drugs to reduce the risk of rejecting your new organ. But the immunosuppressive drugs also reduce your immune response to viruses, and therefore women who've had an organ transplant are at higher risk of cervical cancer because of HPV persistence. So we can vaccinate. This is the good news. There are 3 types of HPV vaccination on the market at the moment. Cervarix, which I believe is more commonly available in Nigeria, it targets HPV 16 and 18, which, if you remember, I said are the 2 commonest HPVs that cause cervical cancer. Then there's Gardasil, which targets HPV 16 and 18, but it also targets HPV 6 and 11, which cause genital warts. So it protects women from genital warts and from the cancer-causing viruses. And then the newest on the market, which is Gardasil 9, as well as protecting against HPV 6 and 11, protects against 7 of the high-risk HPVs, and therefore consequently should be more effective. Now, people are familiar, I think, with girls being given the HPV vaccination. In the UK, it's given to school-aged girls between the age of 12 and 13. But actually more recently, and I've changed it from girls to children, from 2018, boys have been included in the school's vaccination program. It's actually effective in everybody up to the age of 45, both males and females. So if you're under the age of 45 and are considering how best to protect yourself, it's worth considering being vaccinated against the high-risk human papillomavirus. And it's suitable even if you've been previously exposed to HPV or if you have current HPV infection, because a lot of people think, oh, I've had HPV, therefore the vaccine won't work. It will still work. And in children, 2 doses are given. In people over the age of 15, you need 3 doses, 1 at time 0, 1 at 2 months, and 1 at 3 months. Sorry, at 6 months. So all 3 doses have to be given within 6 months. Actually, more and more data is showing that a single dose is effective, and it is likely that in the future, it will just be a 1-dose vaccination for everybody. And that makes compliance much easier. So I alluded to the fact that boys are now included in the school's vaccination program. And if you're a parent, I would say vaccinate both your girls and your boys. HPV vaccination, as well as causing cervical cancer, can cause head and neck cancers and penile cancers. These cancers are very rare, but vaccinating boys protects them against it. But it also protects the girls because it introduces the concept of herd immunity, which means that if boys are protected, then girls are more likely to be protected. And there are some girls who may not be able to get the HPV vaccine because they have some sort of immune condition. Well, if the boys are vaccinated, then the HPV circulation within the sexually active community reduces, and therefore the girls are also protected. So, does this vaccine work? Well, I'm just going to share with you a study that it was a Swedish study that was published in 2020, and they looked at 1.6 million women between the age of 10 and 30 who had received Gardasil 4, which is the vaccine that protects against HPV 6 and 11 and 16 and 18. Girls who received the vaccination under the age of 17 years had an 83% reduction in cervical cancer risk. Now that's really significant. If you received it over the age of 17, but below the age of 20, it's an 11% reduction, and over 20 years, 6% reduction, which isn't 0%, but it's not as good. So the take-home message is the younger you are when you receive it, the more effective it is. And if you go through the internet, you see a lot of rubbish like this about the fact that HPV vaccine causes everything from infertility to death. Just ain't true. It's a really safe vaccine. Over 270 million doses have been given worldwide. And the common side effect is an allergic reaction, which is actually very, very rare. It can be associated with fainting, but teenage girls faint anyway, and I probably would faint if somebody tried to give me an injection. So I don't think that that's a side effect to be concerned about. No other adverse reactions have been identified, and this has been an extensively studied vaccination. So the Global Advisory Committee on Vaccine Safety considers HPV to be an extremely safe vaccination. Nothing to worry about with your children receiving HPV or even yourself. But even people who've been vaccinated still need screening, because if you remember, the best protection was 83%. So whether you've had HPV vaccination or not, you still need to attend for regular screening. This is the screening schedule in the UK. First invitation at the age of 25, every 3 years till the age of 49, and then 5 yearly from the age of 50. And if you've been screened regularly and all your screening has been negative, then you're discharged from regular screening at 65, but you can still ask for screening if you want it. Now, this is based on people who have had regular screening at every interval, and it's always been negative. And it's also based on NHS coverage. Ideally, women should be screened annually. Screening once a year is the safest way to protect against cervical cancer. It may be that there's changes in the vaccinated population where the risk of cervical cancer is even lower. Those interested in history, because we often refer to cervical screening as pap smear, and that's because it was discovered by a Greek scientist in 1928, Georgios Papanikolaou, hence the pap for pap smear. And he discovered in 1928 that he could collect on a glass slide cells that are shed from the cervix and stain them to detect cervical cancer and the precursor lesion for cervical cancer. And that's remained the standard for many years. You go and have a smear, and it's looked at under the microscope. And that's why we call it cervical smear. But we've moved away from calling it cervical smear. Don't actually like the word smear. And we call it cervical screening. And this is because we've moved largely away from looking for abnormal cells. We've looked to looking for HPV in the cervix. And generally speaking, what happens is you have a test looking for high-risk HPV and abnormal cells. And if you have a combination of high-risk HPV and abnormal cells, then that is better at protecting you from cancer than looking for abnormal cells alone. So the equipment has changed. Now what we do is we use a soft brush and we put the specimen into a liquid suspension. And in that liquid suspension, they can look for both the abnormal cells and the HPV. And some of you of my vintage will be familiar with this wooden spatula, which is what we used to use to collect cervical smears. So what happens if you have an abnormal smear? Well, first of all, I think I need to emphasize it is not a cancer test. It's a test to protect women from cancer. So it doesn't look for cancer. And a lot of journalists use the term incorrectly, and they say it's a cancer test. So you pick up changes which are not cancer, but if left undetected or untreated over several years, can put a woman at risk of cancer. And these tests are these changes are fully treatable. So a smear is a screening test. It says that you're likely to have these abnormalities. And then you have to go for the diagnostic test, which is called colposcopy, which is simply looking at the cervix under magnification. And biopsies may be taken. And if there is an abnormality, then a simple treatment is performed. It's an outpatient treatment, and it serves just to remove a small part of the cervix where the abnormal cells arise. It's about the size of a thumbnail, and the cervix will grow back. 90% of women only need one treatment. Most are treated as outpatients, and it is a very effective procedure. But there's no procedure that doesn't have side effects. And it's called a LETS procedure, loop excision of the transformation zone. The transformation zone is the area where the abnormal cells arise. Taking out a bit of cervix can make the cervix shorter, and the word we use is incompetent. So under the weight of a growing pregnancy, the cervix can start to open, which increases the risk of miscarriage or premature labor. The risk is increased if somebody's had multiple treatments or had a large amount of cervix removed. But miscarriage or premature labor is not inevitable. The most important thing is that if you've had a LETS, you tell your obstetrician, I've had a LETS, and they monitor the cervix during pregnancy. If it starts to shorten, a stitch is inserted to reduce the risk of miscarriage or premature labor. The opposite can happen, and the cervix can become very narrow, which can either mean that menstrual blood does not escape, or that the cervix does not open during labor, leading to needing a cesarean section. And the risk is greater in postmenopausal women, or again, if more than one procedure has been performed. And if menstrual blood does not escape, it can lead to cramps at a time where you expect your period, but with little bleeding. And that should be a sign to alert women to seek help. Now, despite everything I've said, and despite the fact that I've said that cervical cancer is preventable, we still have a problem in Nigeria. So this map looks at cervical cancer incidence throughout the world, and the darker colors are the countries with the highest incidence. So South America, Sub-Saharan Africa, and parts of Southeast Asia. And you can see Nigeria is one of the countries with the highest incidence still. And it's because we don't have universal vaccination, and we don't have universal screening. But this is a privileged audience, and we can avail ourselves of all the strategies required to protect women from cervical cancer. The other thing that's happened, and these again are figures from the UK, but I suspect that they're replicated all over the world, is there are two groups of women who shy away from having screening: the very young women and older women. And I think that certainly with older women who've gone through the menopause, having the test becomes more uncomfortable, and therefore, and also people don't perceive themselves to be at risk. So if you haven't been sexually active for several years, you think, well, I don't need to go for screening. Not true. You still should go for screening, because HPV infection can persist over several years. So if we just turn our minds to how we can overcome obstacles to women attending cervical screening, one of the issues with screening is people, the same way that Leye alluded to the fact that men may be embarrassed about having a finger put into their bottom. Some women just simply find it unacceptable for another person to examine them and insert an instrument so that the cervix can be visualized. This in the future, self-sampling, in other words, a woman takes the sample herself, will become more and more common. And Cancer Aware Nigeria, who I know are on the call, are starting a pilot to look at self-screening for cervical cancer. And I've put the website details on here for people who are interested in the pilot. The other reason why a lot of my patients say, well, I don't want to go for a cancer test because I don't want to be told that I have cancer. I've already alluded to the fact it's not a cancer test. People who have regular screening are unlikely to get cancer. It is a prevention test. A procedure can be painful. If you're postmenopausal, you can get discomfort, because postmenopausal women get vaginal dryness. And there's a very easy fix to this. Using an estrogen gel for 10 days before the test. Use it for 10 days and you stop a week before the test, makes it much more tolerable. Some people are put off going for screening because they've had a previous negative experience. And I say to my trainees, if somebody finds it painful, stop, don't force it, because then you set up an aversion reaction where they find it much harder to keep going for smears. Then the other reason a lot of people go, I can't find a convenient time. And there's a lot of stuff bandied around. You can't have it. You can only have the test when you're mid-cycle, can't have it when you're pregnant. You can have it at any time except if you have a period. Even at the tail end or the very beginning of a period, if you're bleeding very lightly, you can have the test done. So you don't have to rearrange your life in order to get the test done. There is also a perception of a low risk of cancer, or the idea that HPV, I've only ever had one partner, therefore I cannot get HPV. It only takes one partner to get HPV, and anybody who has ever had intimate relations is at risk of HPV and therefore eligible for screening. There is also negative associations with HPV, that it's associated with promiscuity, that you don't get it if you're not promiscuous. Again, untrue for the reasons I've already said. And then, of course, there's this group of women who find it extremely difficult to be examined if they've had a history of sexual abuse or assault. And these people need a psychological intervention to be able to make them avail themselves of screening. And of course, self-screening, when it becomes available, may help this group of women. So that's all I'm going to say about the subject, except to summarize. Cervical cancer is potentially preventable. There are 3 strategies: lifestyle. Stopping smoking is something that women can do. It's a modifiable lifestyle factor. Availing yourselves or giving your children the vaccination, and everybody attending for screening. And it's important that we assure good participation in all aspects to reduce the burden of cervical cancer in Nigeria. Thank you.
Thank you very much. Thank you very much, Adeola. I don't know if it sounds very mundane to talk about. Sorry, Adeola. Yes, it's a very mundane talk about menopause and premenopause and at this point. Just a few.
So I highlighted the difficulty that menopausal women have with having cervical screening. perhaps shied away from talking about the menopause as a subject because it's a huge subject, but I will say a few words. One is, it's a rite of passage. Every woman becomes menopausal if you live long enough. The age of the natural menopause is it's 51 plus or minus 2 years. And basically, what is the menopause? Because there's a lot of rubbish in the press at the moment of, I haven't gone through my menopause yet, and the woman's 70. Menopause is when your periods stop. It's a time zero. It's a retrospective diagnosis. If you haven't had a period for a year, then you are menopausal. Doesn't matter if you have symptoms or not. And I think a lot of people, because of the way it's reported in the press, relate the menopause to the presence or absence of symptoms. A lot of people don't have symptoms. If you have symptoms, it's often hot flushes, night sweats, vaginal dryness, as Iona referred to earlier, achy bones, joint pains, and more seriously, it can increase the risk of cardiovascular disease, and it can increase the risk of bone thinning. So to be healthy through menopause, it's important that you eat well, that your diet has that you have enough vitamin D. I don't think we have a problem with that in Nigeria because we've got enough sunshine, but then we tend to shy away from the sunshine. Vitamin D and calcium help to lay down healthy bones. Weight-bearing exercise, by which I don't mean that you have to carry weights in the gym. You should do, so swimming is good exercise, but it's not weight-bearing because there's no gravity. So walking, jogging, weight-bearing exercise helps to keep your bones strong. Making sure that you have, so fish oils help cognitive function, help your brain to stay active, and also helps to lubricate your joints so you're less likely to get joint pains. And using a vaginal moisturizer regularly, a non-hormonal vaginal moisturizer, just like you use hand cream and face cream, should stop vaginal dryness. Some women still need more support, and those women should consider HRT, but it doesn't have, being menopausal doesn't automatically mean that you have to have HRT. Certainly if you have a premature menopause because of surgery or because your ovaries fill early, HRT is an option for those women, but not everybody needs to have HRT. It's a discussion that you need to have. So that's a very whistle-stop tour through what the menopause is and what you should expect and what you should do about it. But most people are absolutely fine, and most people power through. Some people are not. But I think there's very much a narrative that you should expect to suffer, just like there's a narrative that you should expect to suffer when you have periods, which is not necessarily true.
Right, thank you very much. So we can stop sharing now. So we're going to go to questions and answers. Apparently lots of questions and answers and questions. So they're all in the chat. So Leye, can we go back to you? And Adeola as well, so we can try and answer as many questions as we can. Adeola?
Yes, I was waiting for Leye to go first.
Oh, okay, fine.
We've got the list in that order.
You can go first anyway, it doesn't matter.
Okay, I'm just trying to find which ones are for me. So question for both doctors, is there any truth in the suggestion making rounds these days that making the body more alkaline prevents diseases, including cancer? Short answer, no, there is no evidence. Eating a balanced diet, rich in antioxidants is good. Can women over 50 have the vaccination? Yes, but it's unlikely to be effective. As you saw from what I said, the effectiveness of the vaccine declines with age. It's licensed up to the age of 45. And after 45, I don't think that there is really very much advantage to having the vaccination. How can HPV be treated? Good question, because I didn't answer it. HPV is a virus. It's like the common cold. You can't treat it. You have to rely on your body's immunity to get rid of HPV, which is why a healthy lifestyle helps, and avoiding smoking helps. And the vaccine reduces the risk of getting HPV in the first place. Can young adults still get HPV vaccine? Is it restricted to 12 to 17 years? It's licensed up to the age of 45. obviously the optimal age to receive it is when you are under the age of 17, but you can still get it up to the age of 45, and it's still worth going to have the vaccination done. Cancer Aware Nigeria, in the chat box, how you can get your vaccination and the website. Please do look at the chat and copy the web address, because I think that anybody who is struggling to go for cervical screening might want to consider having a self-test. Can women over 50 have the vaccination? Oh, so I've answered, I think, all of those questions. It's just a summary. And I think that's the end of my questions. Breast cancer, right?
Okay, thank you for that.
Could I quickly answer the breast cancer risk question? Increase with age, and what are the tips for preventing breast cancer? Maintaining a good weight, increased weight increases the risk of breast cancer. Excessive alcohol, because alcohol is metabolized. Basically, increased estrogen increases the risk of breast cancer. Alcohol is metabolized to estrogen in certain in the body in women. And a family history. Be aware of your family history. If you have a high family history of breast cancer, you must go for breast screening. And all women over the age of 45 should have regular breast screening. Okay, I'm going to hand over to Leye now so we can cover everything.
Great. Thank you. That's fantastic.
Excellent, thank you for that. Looking at the questions, the Q&A section for me, the first question was, aside from medication, what else can we do to promote prostate health in men? Again, webinars like this is fantastic. Just creating awareness, having annual medicals, once you age 50, I would certainly recommend it. If you have a sibling or father's had prostate cancer, then from the age of 45, definitely PSA blood test and perhaps an MRI. The next question was, is there another way of checking for prostate apart from the digital examination? Yes, we do less and less of that in the Western world. MRI is becoming a more sensitive tool to screen for prostate cancer. So I should use the word screening because we avoid screening because we don't meet the criteria, but for assessment for prostate cancer. So we do MRI. The other sad thing is it is expensive and it's not readily and easily available in Nigeria. So what age would you recommend PSA testing for men of color? I put in the chat box already, age of 50. If you have a strong family history, I would drop that down to 40 to 45. If you had a sibling, if you had two siblings, I'd even drop it down, the age down even further. Colonoscopy for men, at what age should men commence and how often? I think if you have wives, your husband's 50th birthday, you should march him down to see a gastroenterologist. All men from the age of 50 should really be having a colonoscopy that we call it a top and tail, a gastroscopy and colonoscopy is certainly worthwhile. How often? I would say every 5 years should do the trick. So for men with a first degree relative who've had prostate cancer, i.e. father, brother, so I've already given my response to that. If you've got a sibling, then definitely having your PSA checked at a younger age will be beneficial. I don't think I've missed any other questions. Gbolly, is there any other query, any other areas we need to touch on?
Yeah, the floor is open, really. I mean, anyone that wants to talk, ask other general questions can raise their hand and talk to you, Adeola.
Can I? Yeah, I'd just like to mention something.
Yes.
During my conversation on erectile dysfunction,
Yes.
I can't emphasize it more. The need for cardiovascular screening. So if any man is suffering from erectile dysfunction,
Okay.
I think if you come forward to have medical screening, you might be reducing your risk of having a heart attack or having an angina, having a stroke. So ED is like the, how can I say, prerequisite, really, risk factor. 5 years on, there's been some studies from Italy that a lot of men who have cardiac symptoms had ED 5 years earlier.
Wow.
So I would strongly recommend that, if you have ED, come forward, have it assessed, because you could be saving your life.
Excellent.
There's an additional question that's just popped in, which says, how can you avoid or prevent cancer of the soft tissue in women? And that's from Charles. I'm assuming, do you mean of the genital tract? I'm going to I'll answer. We've done a little bit about breast cancer prevention. Genital tract cancers, there are 5: ovarian, fallopian tube, womb or uterus, cervix. We've covered cervix extensively, so I won't do that anymore. And vagina and the vulva. Interestingly, vulval cancer is also HPV related in the vast majority of cases. So having the vaccine reduces the risk of vulval cancer. The vulva is the skin on the outside of the genitalia. Womb cancer, also known as endometrial or uterine cancer, is associated with having a high body mass index. And the reason for this is the estrogen, which is one of the female hormones, stimulates the lining of the womb. And if you had estrogen unchecked, the lining of the womb would grow and become malignant. The second hormone that women produce during the reproductive life is progesterone, and progesterone ameliorates the effects of estrogen. Estrogen is also made in the body fat. So when you go through the menopause, the ovaries stop producing estrogen and progesterone, but the body fat continues to produce estrogen. And so women with a high body mass index are at extremely high risk of endometrial cancer. So weight modification helps with breast cancer and endometrial cancer. With ovarian cancer, it's really being aware of family history. If you have a family history of breast or ovarian cancer, it means that you might have an inherited gene, which some of you may have heard of, the BRCA gene. Some people call it the Angelina Jolie gene because she publicized it. She had her ovaries and her breasts removed at a young age to reduce the risk. And awareness of family history is really important. We can't screen for ovarian cancer in the way we can screen for cervical cancer. So the only way you can risk reduce is when you've completed your family to have the ovaries removed.
So what's the questions coming in the chat?
Okay. So apparently there are lots of questions also coming in the chat, and I hope the gentlemen as well also being a bit more open. There are lots of questions even in my head, which I find it very difficult to ask.
Please ask away, please.
The way you talk about the erectile dysfunction stuff, about how people should just come in. Some people, or some men, erectile dysfunction different ways. They have erectile dysfunction with probably their wives, but not with a girlfriend, or with a girlfriend or not with wives. So how does that work?
Well, firstly, my disclaimer: I'm not a counselor.
Yes.
So that's something to be aware of. We deal with the organic aspect of it.
For sure.
But sexual intercourse is a multifactorial thing, isn't it?
Yeah.
There's spiritual, emotional,
financial,
intellectual,
and financial as well.
And financial. Yes, indeed. So there are many factors that one has to take into consideration when you're contemplating this aspect. Yeah. So it's just worth taking into consideration.
Yeah. So Leye, there's some questions you haven't responded to. So one of them said, you said regular sex reduces cancer. Does this apply to women as well? And does the term sex include toys and masturbation, or is it only sex between two humans?
Well, the studies that we have, you can imagine trying to run a clinical trial in these things. It's not necessarily easy. In the 70s and 60s, they were getting away with it. In modern times, to run a clinical trial, looking at the evidence of this is slightly more challenging. So the only issue is around orgasms. The more frequent orgasms you have, the longer the longevity of life is. So whether it's between two individuals or using sex toys, I suspect that doesn't really matter. But I think it's more the general release of hormones during the body, during the orgasms, that actually improves the quality of life. I hope that gives you that
I think it's
answer justice.
Okay, Adeola, there's another question for you in the chat.
I've just seen it. It's do collagen supplements help or hurt? A lot of promotion around this. I'm not 100% au fait with collagen supplements because it's more a dermatology thing. But I think essentially it's supposed to improve the quality of your skin as you get older. And I think certainly they don't hurt. How well they work, I don't know. Yeah, I think things like hyaluronic acid helps to reduce wrinkle formation.
Okay.
Is it advisable for women over 50 to have bone density analysis? I think that if you've had a premature menopause, if you've had the menopause at a younger age, then it is essential that your bone density is monitored. Or if you're on medication, there's some anti-cancer drugs that can have an effect on bone mineral density, then you should certainly do that. It's not part of routine screening. And I think that as long as you bear in mind the things that help to promote bone strength, like just to reiterate, weight-bearing exercise, a diet that has sufficient vitamin D and calcium. I think that osteoporosis is rarer amongst Black people. It just doesn't occur. I think we have different collagen. And for that, it's the same reason why we tend to form keloid and why our skin doesn't age as much. So it's not a big problem amongst Black people. But if you have a family history of osteoporosis, if you've been on steroids for a long time, if you've been immobile for a long time, then it may be a good idea to have regular bone mineral density. Does HRT increase the risk of cancer? It does increase the risk of breast cancer, and it does, in some circumstances, increase the risk of womb cancer. So any medication you take, there has to be a risk-benefit analysis. And there's some people whose quality of life is absolutely destroyed, and under the circumstances would choose to take HRT, but it's a discussion that you have to have with your doctor, and it's on an individual basis. Have I got to the end of my question?
Fantastic. Any other?
There's one more. 13-year-old takes cervical cancer vaccine without screening. I think that I need just to clarify a little bit more. So age 13 is the ideal time to get the vaccine, but then you start to be screened when you're of an age where you become sexually active. So as I said, in the UK, we start screening from the age of 25. Other countries start screening from the age of 20. So the vaccine and screening are separate. So get the vaccine when you're young, start screening when you're sexually active.
There was a question about the colonoscopy for women as well.
Leye, do you want to take that one? Oh, I'll answer it. Yes, I mean, men and women, risk factors are the same. Colonoscopy for both.
Okay, another question about the side effects of having ovaries removed.
If you're postmenopausal, then the ovaries are not contributing to your health and can be removed if there is a clinical indication, like it will prevent you from getting ovarian cancer. If you're premenopausal and you have your ovaries removed, it will catapult you into an early menopause with all the increased risks of losing bone strength, etc. So if you're having your ovaries removed when you're premenopausal, your doctor will have a discussion with you about what to mitigate, what things will mitigate the risk factors of a premature menopause. And there was something else. Continuous cervical screening after having a complete hysterectomy. Good question. No, if you've had a complete hysterectomy, in other words, the cervix has been removed, not a subtotal hysterectomy, then no, you don't need to continue screening.
Any other questions?
One more about the vaccine. Is the vaccine available in Nigeria?
Yes, it is. I think Cervarix is more easily available, but Gardasil 9, Gardasil 4, and Cervarix are all available in Nigeria. There's something about.
Yeah, we can wrap. Well, I guess we can wrap up. It's been very interesting. It's been very enlightening, and it's been very useful. I mean, for most, I'm sure I speak for everyone here. And I, thank you so much for taking time out to prepare for this. Adeola and Leye, and I hope that you find a lot of us coming through your offices over the summer or after.
May I say something?
Yeah, you can.
Okay, so someone made a plea and someone has reminded me about the plea. So I'll mention the plea. It was about asking women to be open to more sex. And the plea was, in view of the correlation between frequent ejaculation and orgasms, right? And reduce the prostate cancer risk, can you please emphasize to wives, girlfriends, and partners? Let me also say husbands, boyfriends, right? And partners on the forum, that they must, capital MUST, this is the plea, not from me, they must deliver at least 3 times weekly. I don't know what you mean by deliver. Deliver 3 times weekly to save their husbands from the scourge of prostate cancer. So that was a plea
Okay.
that I was reminded about.
Okay. Well, Adeola, I like your smile there, so hey. Well, you're smiling still. My mute.
No.
Okay.
Yeah.
Yeah. Adeola, you're smiling.
I think Leye also said that women are protected as well. So it's not just for the men, it's
Okay.
also for the women and their longevity.
Yes. Yes. Comes back to the topic that we picked, the joys of living.
Yeah.
Living longer.
Yeah.
Yeah. And also, I thank you very much. I thank Lagoon Hospital. I thank Marcel Ruth. I thank Adeola. I thank Leye. And I don't have cancer. Also, I just try to be careful, So guys, you can come to me for your, you call it rubbish advice, but we're good.
All right.
All right. Thank you so much, everyone, for joining, for coming to this webinar. We're going to do another one very soon. Thank you, everybody.
Thank you. And thank you for the audience for being so interactive as well, because it always helps to keep the conversation going. Thanks for organizing such a lovely seminar.
Thank you. Thank you. All right. Bye, all. And have a good lunch. Yes.
Bye.
Bye.